Hello, everyone, and welcome to our November SimCity rounds. Uh, I'm really thrilled to be presenting with the manager of the CAMH Simulation Center, Ms. Fabienne Hargreaves. Um, and Fabienne is a community health and education specialist. She completed a MA in education from OISE at the University of Toronto in 2015. She's worked in the Sim Center since 2019, engaging in both education and research. Her areas of interest are establishing ethical collaboration with lived experience advisors, clinician capacity building, and educational technology tools. Her research includes the use of virtual reality in psychiatric simulations and evaluating training approaches to staff safety and self-protection skills in the mental health setting. Previously, Fabienne worked as a behavior therapist in her past life in the community and draws from her clinical background to inform her current work. And I have to add my own little extra to this bio. You are a pleasure to work with, and we're so fortunate to have you. So
Stop
Fabienne
it. That's too
is
kind.
Fabienne's going to introduce me now, which is
Yeah, I mean, it'd be wild if you were attending these SimCity rounds and you don't know who Petal is, but just in case, Dr. Petal Abdool is a geriatric staff psychiatrist at CAMH with us, the Center for Addiction and Mental Health, and also a consultation liaison geriatric psychiatrist at Providence Healthcare. She is the assistant program director for internal medicine graduates and an assistant professor at the University of Toronto in the Department of Psychiatry. She's also our inaugural medical director at the CAMH Simulation Center. So that's why Petal and I work so closely together. And also the faculty lead simulation education integration for the Temerity Faculty of Medicine at U of T as well. And her area of research is focused on the use of simulation in medical education. So a lot of titles Petal has, a lot more than me, but we're both very excited to be here today and just talk a little bit about our experience in developing virtual reality simulations.
Thanks so much, Fabienne. So our talk is entitled Designing, Developing, and Implementing Mental Health Virtual Reality Simulations, Lessons Learned. So Fabienne and I have no conflicts of interest. Our learning objectives are going to be around understanding the process of designing a VR sim, and Fabienne is going to take the helm for that piece because she has been involved from the beginning, and describe some of the considerations when collaborating with a variety of key stakeholders. And then finally, we're going to talk about the benefits and the challenges that arise when you use VR as a training modality. So I know I'm preaching to the choir here when I see the names like Lindsay and Sandra, and I know many of you are involved in medical education. So we know the benefits of simulation. It avoids risk of harm to patients. Ideally, there's a safe, brave space for learning to occur. It allows us to experience low frequency but high acuity events, where we know that skill decay is a common phenomena that happens to all of us. And so these low frequency events that require us to really be on the ball, because lives are at stake, it's important for us to practice and to be able to prevent those skills from getting rusty. So it's appropriate for use in communication skills scenarios, even technical skills, as the SimSinai. A lot of our sim centers run surgical simulations. And then we have the fact that it allows for safe practice, to build confidence, to allow for mastery learning. And the critical piece is that post-event debrief, where you get that reflection and that consolidation of learning. And of course, the idea that unlike a ad hoc clinical setting, you're allowed to create learning objectives and make that experience predictable and consistent, which is in and of itself a real benefit when it comes to medical education. So what do we know about virtual reality in medical education? So the published literature, and a lot of this has come from that Petal paper called Virtual Reality and Transformation of Medical Education, tells us that VR can encompass many different things. It could be 360 videos, screen-based learning. It can be more immersive with augmented reality. Sick Kids has an expensive AR room that they can create that augmented reality experience. Or it can be what we're going to talk about today, which is the use of those virtual reality headsets to experience a specific situation interviewing an avatar. VR has been used widely across medical and nursing fields, and there's a lot of evidence right now demonstrating that it could be effective, and it can afford for experiential learning. So what are the benefits? It's repeatable. You can do it over and over. It can be more engaging. I mentioned the standardization factor. It can be used without faculty. So by that, I mean, you can do the sim and then you can debrief asynchronously. It can be integrated into daily practice. It might, in the long term, be more cost effective than running multiple simulations. And the drawbacks are that it might not be suitable for every educational training. It certainly requires faculty support. And I like to say that VR is one of the many tools, simulation tools, that we use to build that house, that medical education house. It's not meant to replace an expert faculty or educator. So this is the first simulation that we built, and the learning objectives, so it was called VRSRA, Virtual Reality Suicide Risk Assessment. And these were the learning objectives that we had set out on to demonstrate a process of building a therapeutic alliance with a patient, identify risk and protective factors by conducting a suicide risk assessment, and then organize those factors into what we in psychiatry call the 4Ps: predisposing, precipitating, perpetuating, and protective. And then you meet with your preceptor to talk about which of those factors could be modifiable, and then you work with your preceptor to think about your plan. The virtual reality opioid overdose learning objectives were to assess a collapsed patient, to ensure that there are no hazards in the environment, and to understand, why they might be collapsed, look for key signs of opioid overdose, call for help. And then you're expected to administer the required treatment, which is naloxone, and monitor the patient, support them, and encourage them to stay to get formal help through 911. And is this where we play the video, Fabienne?
Yeah, so hopefully if you double click that image, it should then give an opportunity to press play. If it
When I
doesn't,
double click, nothing happens.
all right, I also have here in the chat, here is the link. So if you maybe just want to copy that and then just show it. Yeah.
I'm gonna have to share my screen. Hang on. Thank God there's a long trigger warning there. Bought me some time. Can you hear? You
No.
can't hear the music? Oh. I think I have to click on the optimize. So I think we'll just play it because I think I was supposed to do that before I started sharing to optimize the audio. But there's captions, so it should be okay.
So you'll see we have two different types of scenarios for this one. We have a clinical one, which is the one that you see right now. So this is for healthcare providers who would be using an injection in a crash cart to be able to provide naloxone. And this is our community setting one where you would use nasal spray. So yeah, we have two different scenarios.
And the VRSRA also has two avatars to choose from. One of them is a 45-year-old male, Robert Stevens, and the other is a 19-year-old female, Michaela Mendez. So this is where the person is coming.
What's going on?
No, now we
What are
can
you
hear.
doing here?
What are you talking about? Has what happened before?
So the avatar can speak to you, but you have to choose from a drop-down list of options to interact with the avatar. and then to trigger the next response. So I'm going to pass the torch to Fabienne now, who can share her screen and then embark on our developmental journey, which was one of our learning objectives.
Probably see my notes instead, right? Let me quickly. Okay. Do you see just the slide and not the notes?
Yep, we're good.
Cool. All right. So I just wanted to share a little bit about our development journey for those who might be interested in doing VR themselves, or if you have already embarked in VR, be curious to know sort of how this is different or similar to how you've done your journey. Okay, let me just move this over. All right, so the way that we did it, just very brief overview, is that we were responsible for creating all of the content and creating all of the designing, but the actual game was developed by our VR vendor, and they created it in Unity. So very high level, our steps with working with our VR vendor was to have our needs assessment and scenario design, and then our VR development and testing, and then our pilot and evaluation, which would sound pretty similar to probably a lot of simulation design in general. We definitely follow very, very similar principles and best practice. So for us, one of our lessons learned, and again, this probably is not very surprising for those in simulation, but is to engage subject matter experts early and also creatively. So for us, we've realized that creating VR, and it's probably not a surprise, there's a lot of manpower required with it. And you can sort of see on the screen here all the different types of professionals that were involved in developing this training. For us, the way that we found it to be most helpful was to engage in a sort of hub and spoke model of collaboration. So we chose this model because we required so many experts with so many different variety of perspectives and backgrounds. But also because it requires so much time. So we had our core team that was full of e-learning designers and simulation educators primarily, and we would meet regularly, and by regularly I mean pretty much daily at some points, and then we would engage with everybody else that you see on the screen, and I'm sure others that I've forgotten. That includes a clinical expertise or people with lived experience expertise, our VR vendor, our research, our editors. And we would meet with them about bi-weekly, and we would have team meetings where we're reviewing where we're at. All the stakeholders would also work independently, asynchronously, using some software that I'll share in a little bit. But yeah, we would meet regularly. We would still make all of our decisions together, but it wouldn't be fair to ask every single one of these people to meet every single day with us. So we had our core team that would keep moving this forward, and we would make sure that at all levels of development and feedback that we would be able to get all of the experts to also give their perspective and work through it asynchronously as well. Our second lesson, which again may not be too dissimilar than what some of you might already be doing for simulation development, but it was to develop a terms of reference. And again, given the amount of stakeholders we had, we found that this was very beneficial. The screenshot there that you see is just the categories that we had for our terms of reference, in case that's helpful for you in your journey. I think for us, we're still getting used to using this for every single training that we do. For you, it might already be standard practice, but I think for us, it was really crucial for our VR projects, given how complex they are. So for us, successful collaboration stemmed from ensuring that all the project requirements and all of the team members' roles were very clearly understood from the beginning. And so creating this terms of reference really helped us lay the groundwork for crucial discussions and project initiation. And the structure and the content of the terms and reference, as you can see here, the main buckets were the needs assessment, target audience, learning objectives, time, scope of each role, workflow, commitment requirement, and then the transparent process for decision making. So similar to sim, right? Not very different than other modalities for sim that you might do. But our document was probably larger than we had for a lot of our other simulations. All All right, the next one was lesson number 3 was for a vendor matrix to help us decide who our vendor should be. So right, we did everything in-house together, but then we needed an external vendor to actually develop our vision and work very close side by side with us. So we had our e-learning designer sort of lead this process for us, and they sort of shared with me that the best practice is to have a vendor matrix and that we sort of do it blindly and independently. So together in our core team, we created these 5 criteria, and here you can see that it was a combination of both like technical needs, budget, having the right expertise identified by the VR vendor, and also the sustainability post-pilot. Because as Petal had mentioned, the type of VR that we did is one that is built in Unity, and because we don't have Unity expertise, that means that we need to have some sort of mechanism to be able to make updates, given the fact that we're not able to do that in-house at this moment. So we developed these 5 different, 5 high-level criteria, and then we went down and we broke down within each criteria what that looked like. So this is just a screen cap of the part of the first one, which was our technical requirements. So there was about 2 to 3 times longer than this, but this just kind of gives an example of like how the level of detail that we went into, the ideas that we had in terms of what the technical requirements were before we even worked with a vendor. And naturally, some of this had changed a little bit. Like for example, the progress bar that you see in the 3rd line wasn't something that we ended up keeping, but we did end up bolstering out more the report card that you saw in the video closely at the end, which kind of details more the things that learners successfully did, some of the things that they forgot. So we each individually went through and rated we tried to blind the different vendor applications, and we each individually went through looking at our criteria that we developed together, and rated each vendor, and then we came together, put all of our numbers together, met, and decided together on who the successful vendor was. After that, what we ended up doing was learning a lot about how beneficial it is to have capitalizing on free digital tools to just be able to work together with our wide range of stakeholders. So some of you may already be familiar with Miro. This is a tool that we ended up using a lot in both of our VR developments for suicide risk assessment and opioid overdose. And for us, this having people come from such wide range of backgrounds and different fields, and knowing that none of us really were necessarily a VR expert who had all of this previous VR experience, we needed to find creative ways for us to all conceptualize such a sort of dynamic and challenging type of modality. So this is where Miro came in for a lot of us. So Miro, for those who aren't already familiar, is sort of like a virtual whiteboard where you can collaborate on a wide range of tools or projects, and it can also be done synchronously and asynchronously. So it's very similar to Google Docs that way, where you can see each other working and anybody can get access to it. And the benefit of that is also that we don't have version control issues, right? When you're constantly doing iterative design, you're always tweaking, you're always iterating. And so having this be on the cloud was very helpful for any of us to be able to go in real time or on our own time and be able to tweak it. So this is an image that shows a little bit of our storyboarding that we did for suicide risk assessment, and all the different colors and shapes mean something different. But this was crucial when we were kind of developing the story and the branching and how learners would kind of go through the game and what type of questions they might ask and what results that ends up having in the game. So this is a bit of a snapshot. In the next slide, you'll also see a little bit more information around sort of like how else we used Miro. But yeah, we're not getting a kickback by any means from this. This is a virtual free access tool, but we just have found it tremendously helpful for the designing, conceptualizing of our project. So we thought that we would share. So here you can see again the other ways that we used Miro. So it was our space for all of our resources. You saw a lot of pictures before, and these were the pictures that our VR vendor was able to recreate in the game to make sure that it was accurate. Our policies, our evaluation tools, everything was sort of housed in different sections on this one board. So it's just kind of eliminated the need for having multiple different type of software doing different parts of this. I mean, I will say that there is a learning curve for software like this, especially when you have a wide range of stakeholders who may or may not be super comfy with tech. So this is a thing to keep in mind also of how do we support stakeholders in scaling up into using this software so we can actually get their voices heard and captured properly and accurately. The second tool that we used that was also free access was Twine. So this is an open source tool for non-linear stories. So we used Miro in all the different ways that you sort of saw captured in the previous slide. But one of the challenges that we still came across was when we start writing a detailed script, so we especially think about virtual reality suicide risk assessment, it's very detailed. Depending on how a learner starts a question is going to change how the patient responds to you, right? If you jump right in, they're not going to be so pleased with it. If you focus on building some rapport, it probably things will go a little bit easier for you. So that just created a lot of complexity in trying to figure out how do we capture this very branching heavy dynamic script. So you can see the GIF here a little bit where we had all of our branching sort of mapped out on the left-hand side on the back end. It's a little bit like a flight path. And then you can see the user experience. So on the right-hand side, we just very, like bare bones, just copy and pasted our questions and our answers. And then we could practice clicking it and sort of going through that experience and seeing what works, what doesn't, what feels unnatural, where do we need to add more, where do we need to add less, where can we jump around? Yeah, so just for any sort of non-linear script development, this was a very, very helpful tool for us. And especially for our subject matter experts, where you think of clinical subject matter experts or lived experience subject matter experts, it's quite likely that they don't necessarily have this level of simulation or non-linear script experience. So this was a really nice tool to be able to send them a link, have them just use the right side of the screen where they click through and they can kind of provide feedback of your script before and during our VR vendor developing it in Unity. Our fifth lesson was around EDI principles. So again, very much aligned with our principles in simulation outside of VR as a modality. A couple of elements that I just want to touch on is working with people with lived experience. Obviously, there's many benefits to it and necessities to having people with lived experience be in all of our simulations from the onset. But also just wanted to name how important it was also for, it was exactly as important as any other sim when it was for VR as well. So a couple examples are for suicide risk assessment. They provided a lot of feedback on what is realistic response from patients and how that patients might respond differently based off of different approaches to an interview, right? So if you go right in and ask a very intense question from the beginning, how they're going to respond, how some versus if you had a little bit more of therapeutic rapport. And for our virtual reality opioid overdose, they talked a lot about the importance of staying after you've temporarily reversed an overdose and what are supportive ways to communicate, what are non-supportive ways to communicate, what are some of the experiences that might be happening sort of viscerally and psychologically and emotionally when you're coming to after an overdose. And also some of the fears that might be happening. So for example, if you're using a substance that is still illegal in Canada, the fear of having police come when you say I'm calling 911 to have a medic come and support you, and like what type of conversation do we need to have to help hopefully have the person stay on site to be able to see him by a medic without making them fearful for any legal repercussions or anything like that. I think the consideration for when you're developing VR is having a budget for this. So Petal talks a lot about VR being a tool of the rich. I mean, it is not cheap, I think, by any means. But it is important to also properly pay our lived experience advisors from the beginning in all of this. And because it just takes a little bit longer to get comfortable with Miro, because it takes a little bit more comfortable time to get comfortable with VR, it just takes a while for us to be able to properly and most effectively elicit everybody's feedback. So just thinking about the budget from that in the onset. As well, accessibility. So there are currently, from our understanding, no approved accessibility standards for virtual reality at this time. We do know of sort of extended reality guidelines that are quote unquote unpublished. So we did reference those, and those are from the Web Content Accessibility Guidelines. And so we did kind of use that framework, and we tried our best to include things like pre-recorded captions, color contrast, text size, the way that you can pick things up using one hand or two hands. Also having desktop be prioritized. So we developed desktop the same time as the headset. So for those who might not be able to tolerate VR very well, and Petal will talk about that a little bit shortly. But I think we're far from being able to say that VR right now is a very accessible modality. So we tried our best, and if anybody knows of any other accessibility standards for VR that we don't know about, please share them with us. We tried our best, but I think there's still room for VR in general to be more accessible as a modality. So our next lesson is allocating a significant amount of time to user testing. So I mean, I've highlighted a little bit so far in the talk the importance of digital and collaborative tools, but really these tools are only as effective if we build enough time to be able to go through all of these levels of development with our stakeholders. And feedback and this iterative design has to be continuously embedded in like almost every single week, every single meeting. And so for us, when we got to the point of actually having to do user testing, right? So we have a modality, our vendor gave us a version of our game, and now we need to test it with our stakeholders, which include people of our team that I've already mentioned, and also end users like students or other clinicians. We realized that when we were doing user testing for our first one, which is suicide risk assessment, we only did 2 stages of testing. And we realized very quickly that that wasn't not ideal. It was not enough to be able to capture the changes and get more feedback. So for our opioid overdose, we ended up doing 3 stages. I would argue if you had infinite amount of time and resources, it would be better to even do more than 3. But 3 was definitely more successful. It gave us more time to iron things out than having 2 versions. And so the process for this user testing was that we would have somebody from the core team meet with each individual test user, and they would put on their headset or play the game on the desktop, and they would verbally share all of their feedback, which would be transcribed. And then after, they would also complete a survey, and we would also conduct sort of a semi-structured interview as well, just to make sure that we've captured all levels of feedback. And then our e-learning designers kind of like collated all of that and then brought that back to our VR vendor, and they made these changes, and then we repeat that. So for us, I think one of our learnings is just to be very realistic about the time that is needed for all of VR development, especially user testing, just to make sure that we're not ideally making that go a little bit too quickly, and then we're not capturing all of the voices. So this is just a very quick overview of the type of feedback that we have received in case it's of interest to anybody. So you can see here a little bit the iterations of first, second, and third. And it just gives a little bit of insight into the collated level of feedback and the things that we had changed between the first one and the second one and the third one. So I can just leave that up for a couple minutes. So as you can see, it also reduced, right? Ideally, after we're going through these iterations, there's less and less feedback and less things that have to be changed. So by the final one, it was really just like little tweaks to the way things looked or text or audio. So I'll say those are our main sort of lessons learned throughout our process. A couple sort of bonus thoughts that were important for us to include in this that we've learned that didn't kind of neatly fit into the different lessons. We're just kind of thinking through what type of headset you would want. So we, going through this ourselves, we started off with one type of headset, which was tethered, and it had sensors sort of outside on the room that the headset and the controllers would speak to. And then for us, we sort of realized, how cumbersome that is. And we take VR in a lot of different places, and it wasn't always feasible to have that. So we ended up going for non-tethered headsets that are cheaper, not as fancy, but are easier to move, easier to have multiple in the same room. So we could run sessions up to 20 people in 1 or 2 rooms. So just thinking through like what is important to you. Is it the ability to have high fidelity visuals? Is it to be able to easily set it up or transport it? And for us, both headset and desktop builds were completely necessary from the beginning. I think headset is something that's wonderful to bring people into the space. It's bright, it's shiny, people love it. It makes them engaged. They always lose time in there. We have to sort of be their parents to say, hey, you've been in this long enough. We actually need you to get out of it so you don't start feeling nauseous. But the desktop is definitely the one that is more accessible, is easier to disseminate. Right, so our virtual reality opioid overdose one, for example, is a little plug on our website. You can access the desktop one from anywhere. You don't need us, you don't need headsets to be able to do that. Just the less is more. We've mostly already talked about that, but just finding software, it doesn't have to be Miro or Twine, but just finding software that's able to do multiple things for you, because you just need so many different things in VR development. So just finding ways to reduce the amount of version control or software that you need, having flexible software in your design process. I say the fitting a square peg into a round hole, just thinking about the type of VR. So Petal had mentioned one of the first slides that there's various types of VR. We're talking about one specific one that is built sort of within Unity and that you can play, but there's 360, there's AI ones that you just use and communicate with. And I think it's important to think through what your goals are in VR and what is the best VR to be able to achieve the goals that you want. And again, no surprise, but it's exceptionally resource intensive. And for all of us who are in sim, we know that sim in general is resource intensive. And, the first time that we went through VR a few years ago, I think all of us, our minds were still blown of how resource intensive it is. So just really giving yourself ideally the time, the space, funding, if it allows, to just like take your time, have a lot of check-ins with all of your stakeholders, have a good amount of user testing to be able to make sure that you have a good product before you pilot it. And just that sometimes the headsets aren't going to work for everybody, and that you're going to have some folks who just can't quite adjust to it or have some tolerability issues, which I will now pass over to Petal, who will speak a little bit more about some of the research that we've done, which gets to this tolerability issue.
Thanks so much, Fabienne.
Petal, do you want me to keep the slides up for you and just go through them, or you want to do
No,
anything?
I won't be able to advance them, so you can just stop and I'll
Sounds good.
got my slides ready to go here. Okay, so I'm just going to take you on, so Fabienne took you on the journey of how we designed and implemented our virtual reality trainings. And now we're going to move into the benefits and challenges, which was our last objective of this training modality. And I mean, when you're involved in something that's so innovative and so new, novel and innovative, there are so many roads that you could pursue from a scholarly perspective to understand its efficacy, its effectiveness, as well as the drawbacks. And I think you have to keep in mind, even though you're excited about some new innovation, that there are going to be downsides, and you want to make sure that you study those well, because you don't want to implement something that cannot benefit everyone or that might exclude others. So the first thing we did was comparing the experience and the efficacy of the desktop VR training to wearing the actual headset. So this is a paper that we published this year in Clinical Simulation in Nursing. And it was looking at, so I'll just preface it by saying that we were able to embed the virtual reality suicide risk assessment training into the Lawrence Bloomberg Faculty of Nursing curricula. And so we had roughly, I think at the time this paper was published, over 300 nurses had done the desktop training. And we had also brought in some of our student nurses at CAMH on placement at CAMH to do the VR headset. So that's where we got the data from. And what we wanted to see was the educational outcome, what the learner experience and user satisfaction looked like. And we wanted to compare the two. So we had about 52 nurses at the time when we wrote this paper up on the immersive experience of the headset with the handheld controllers. And then we had the desktop version, 187. That number was much larger because, as I said, it was already embedded into their curriculum. So we found that there were comparable improvements regarding the educational outcomes, user engagement, and overall user experience. The benefits could vary depending on the type of content being taught, but we thought that, I guess maybe because of the fact that you're just sitting there and interacting with an avatar in a communication scenario and there was no actual procedure, that the benefits were quite comparable to both headset and desktop. So this is just some of the methods in more detail. So here we actually looked at a broader range of trainees, from nursing students, pharmacy students, psychiatry residents, as well as physicians. And we had a pre and post evaluation that we used. So this is looking at the outcomes. So you can see for both the headset and the desktop, it's quite negligible, but there were gains made in both realms. And I think that's the important piece. This was a five-point Likert scale that we used, assessing confidence. And then we thought that there was a change around 18 versus 24% between the groups. And we speculated that maybe the nursing students may have had less confidence on the SRA learning objectives compared to residents and physicians because of how they're trained. So that might have been another factor to consider. So this is the user engagement scale comparing both the VR headset and the desktop. So as you can see, the VR headset outperformed in aesthetic appeal, but I would say the other domains were quite comparable. And I think that that's pretty self-explanatory. I mean, if you're in a 3D world and you're doing things, then you probably would be more stimulated and engaged than if you're just sitting at your computer clicking. So then this was a comparison between, in terms of intention to change practice, we see that the desktop was higher. The simulation experience, again, the desktop outperformed. The debrief experience, so for those in the VR headset, they had an in-person debrief with a preceptor, whereas the desktop, it would have been an asynchronous debrief after with their preceptors in their programs. So that could explain why it was a larger difference. And then satisfaction, again, was much higher with the VR headset, and the VR experience led to those who did it feeling that they were much more likely to recommend the training to others. So we talked about tolerability. So there's a lot of literature being published now talking about cyber sickness and the health risks and side effects related to using immersive virtual reality headsets. And so we were very keen to make sure that we understood this. So according to the published literature, we know that around 10 to 30% of people who go into headsets might experience some sort of adverse effect. This can range anywhere from anxiety, nausea, eye strain, VR sickness, possible change in sensory, motor, or perceptual abilities. And in those who are truly susceptible to seizures, it can trigger epileptic seizures. So what we thought was we should really make sure that we administer what we call what we don't call this is a standardized validated scale called the SSQ, the Simulator Sickness Questionnaire. And so in our pre-brief, we do cover all the risks associated. We ask people these questions to make sure that they're not going to be in that group of more vulnerable individuals who might not be able to tolerate it. And if they are, then we usually advise them to do the desktop training. So this is another paper we published this year in Academic Psychiatry, looking at the prevalence of adverse effects in the virtual reality suicide risk assessment training. So of the 22 participants that were captured in this paper, what we found was that our overall scores demonstrated very good tolerability, and the majority of participants reported no or minimal simulator sickness symptoms, and the figures were aligned with around what we see in the literature, which was around 10% had mild symptoms. And this is another study that we're looking into in terms of the severity and prevalence of cyber sickness in virtual reality simulations in psychiatry. And what we did was we went into more detail in terms of the neurophysiological aspects of why people develop cyber sickness. So there were two theories. One is the sensory conflict theory, which hypothesizes that cyber sickness is caused by a mismatch between your visual and your vestibular system, and that this mismatch occurs when the motion that is visually perceived by the user doesn't result in there's a lack of a corresponding movement in your body. So that kind of throws things off. And then the other theory that's out there is that there's the postural instability theory, which states that the loss of postural control during VR immersion can contribute to cyber sickness. So we thought that given that one of our trainings is just sitting interviewing an avatar, which is the suicide risk assessment, and the other one is more procedural, where you're actually assessing a patient, shaking them, moving around in the environment, and then administering naloxone. So there's a higher degree of physical movement. We thought that might be another opportunity to study the prevalence of side effects. So this is the results we obtained. And what we found is that certain domains of the simulator sickness questionnaire were more affected and impacted. So nausea, for instance, was statistically significantly higher for the virtual reality opioid overdose simulation than for the SRA, where you were just sitting and talking to the patient. So we then can conclude that higher physical movement in the simulation was probably likely to have increased the cyber sickness, but only in the domain of nausea. So if you're embarking on your own virtual reality development journey, these are some questions that you're going to want to ask yourself. And Fabienne talked about this as well, the type of build you want. Who's your target audience? How easy is it going to be to get them to come down to your sim center and put on a headset? Or are you interested in something that's more scalable? You want to think about if there's going to be interview or communication skills involved, whether you need a speech or more interactive avatars. And then if there's a procedural element to your learning objectives, then are they going to have to interact with the environment? And then given the cost, the upfront cost, you want to make sure that whatever you're developing cannot be achieved with the more traditional types of simulation modalities, such as standardized patients, mannequins, and task trainers. And then I mentioned this briefly, but scalability. Are your learners on-site or off-site? And what is your goal with the VR that you're developing? And then do you have champions on your units or dedicated space to be able to roll this out, say, in situ or in amongst teams on different units? And then gamification. We know for a fact it increases engagement in our users. We know that it allows for mastery learning, because then you're more likely to repeat it over and over. But then there are some things that can be easily gamified, whereas others might be trickier to implement. So these are some of the questions you might want to ask yourself. Here are some virtual reality articles that really guided us and helped us along the way. If you're interested, we of course could not do this alone. The two of us are presenting, but it was a huge team of experts, subject matter, simulation, VR. So we need to give them all a shout out. This is our virtual reality suicide risk assessment team, made up of the CAMH education staff, content experts, VR vendor Propel, and then our opioid overdose training team. Again, so much gratitude and so much dedication. These are our references. And we have 15 minutes for questions. Thanks, Stephanie. So given that there are two of us, and we're happy to monitor the chat. So I've got a message here asking us to share the slide with the additional reading and references again. Sure.
So maybe while you do that, Petal, if you want to pull up the slide deck again for them to screenshot it, and we can also maybe, yeah, hopefully we can send it around after too. But in terms of conceptualization from like how long did this take? I mean, I think our VRSRA one, which again was our first one, we were a little ambitious. I think technically our development was like 4 months altogether. When you think about conceptualization, development, user testing, piloting, it was about 6 months, which was hectic and tight. But so then kind of learning our second round and then having an additional user testing round as well. Just giving ourselves a little bit of a longer laneway. It was just, I believe, under a year for opioid overdose. Petal, you might know better.
It was less than a year, I think.
Yeah.
We were able to optimize, I think, optimize on the time because we had so much experience from the first round. I think Lindsay's got her hand up.
I do. Can you hear me okay?
Yep.
Sure.
Fantastic. So I want to pick up on something that you said earlier around, I'm paraphrasing, but VR is a tool for the rich or something to that effect. And so knowing that we're sitting here, thinking about us as a cross as part of a network, any suggestions on how we can work together? Because it seems silly for all of us to be creating these when there's opportunity to be a little bit more cost effective, learn from each other's expertise. And so do you have any ideas of platforms or way that we could think about being maybe a little bit smarter about how we're all embarking on this?
It's a great question. So I think you and I are working together to share this. So we did share this with Unity Health through a fellowship that was offered through UHT to Providence Healthcare. So we are sharing our virtual reality suicide risk assessment across the TASAN community and beyond. We actually have both national and international connections and partnerships for both of these trainings. And like I said, we've embedded it in the nursing curriculum. So I think sharing is not the issue, but I think where it becomes tricky is the learning objectives, right? We don't build the VR just out of the blue. We do it based on a gap, a needs assessment. And so sometimes that might not be applicable across every institution, right? And I think that's where it gets to be a little bit tricky. And then if we have people who are asking abroad, for instance, then the language, the accent, a lot of it isn't authentic for them. So that's the other piece to me that seems a little bit discouraging, that because we don't want to be just saying, oh, our content is going to work in your context, because it may not.
I think the one thing I would add that is the benefit of simulation is the integral part of the debrief. And so, as we're all building this, recognizing no content is perfect, no sim is perfect. And I do wonder if there's opportunities as we're all thinking about building, either co-designing. So, Fabienne and I come together from Unity Health and CAMH, and we think about a project, but also that as we're building these, how do we create generalizability and transportability? The accents and some of the cultural competence is certainly one piece. But I do wonder if there's ways that we can do it that would allow for even more transferability across, because there are things that are ubiquitous in our systems: health, human resources challenges, burnout, moral injury. Like there's so many of them. So anyway, just things for us to all think about, myself included. Thanks.
Yeah.
I also think, like, thinking about a lot of the grants, some of the grants that we've received so far are like grants that are not specific to CAMH, and I think those would be the ones that lend itself really well if we were to have enough foresight to think about, can we collaborate across hospitals in grant applications or receiving, versus ones that were very specific to CAMH, which then might lend itself better to providing access afterwards. But it's something, and we haven't explored this too much, but something we've been exploring sort of the past couple of months, and we were in talks with a couple of different people, is understanding that, from my understanding, it seems like there are vendors out there that also do this, where they have different, and Lindsay, you might already know this much better than I do, but they have platforms that they've created to help share scenarios for very specific like vendors or platforms that they use. And so we're also trying to see that, like, how do we not recreate the wheel? How can we adjust and adapt, and or just keep the same that somebody else has, but then, like you said, have our debrief be a very core component of talking about what that means for our context as well.
I think Amar's hand, and then I'm going to address a question or two in the chat.
Yeah, thank you so much for this presentation. I thought it was really impressive, like sharing your process, and like the immense amount of time and energy you put into this was very inspiring. So thank you for sharing the kind of inner workings of what you've done. I know the presentation was on like designing and development, but I'm really curious about some of the outcomes that might have been evaluated with the nursing students, and you know, if there was any efficacy in terms of like competence or confidence doing SRAs.
Can I ask you to check out our article? Clinical Simulation in Nursing. It's
Of
published.
course. Yeah,
And
yeah.
we would love you to read it, so we in more detail, because I don't know if we have time to go into all of it right now, but the article has tables that show the efficacy and the methodology behind how we assessed their responses.
I will try to
Will do.
find a link to that
Yeah.
paper before 1 p.m. and then I can put it in the chat.
Thank you.
And then some in the chat, they said, so Tucker is asking, if we didn't have to worry about resources, time, people, money, what would you want to study next? Thanks, Tucker. I'm gonna tell you that later. I'm not sure. A designer thought it was interesting and informative, Fabienne. And then Johar said, I appreciate your follow-up on studies of tolerability and consideration of causative factors. Curious to know the size of your team and collaborators. So we did show these 2 slides with the names of all the team members for both VR and OO, opioid overdose. If you would like me to post it again, please let me know in the chat. This talk will be recorded, so you can go back and look at it at your leisure and see the names. Fabienne, do you know how many people were on the Propel, the size of the Propel's, the vendors team? I don't know. I only met with 2 of them.
They probably outsourced a little bit more to the junior teams as they also started growing throughout the process. So for Propel on their side, the first time it was about 3 or 4 kind of core folks, and then I think they had a few more. I think in terms of our team, I mean, our sim team itself, we have it's small but mighty. We have 7 or 8 people, and that includes our directors. And so in terms of our core team, when we were developing, we had 1 or 2 sim educators, we had a couple e-learning designers, and that was mostly it for like the who's doing this day to day. So with, let's say, a handful of people. And then in terms of our stakeholders, I'd say is probably we were upwards towards 15 that we would engage regularly. And then our user testing would then be more than that, which include our stakeholders and also end users.
All right. So it's 5 minutes to the hour. Do we have any other questions?
Well, I wonder, maybe we can just put our slide back up. So I'm just having bit of a hard time right now finding the online version of our paper, but we
Okay.
have it. We have that slide that talks about the nursing. So I wonder if we could just put that.
Yeah, he can take a picture of it.
Yeah, and then maybe you could just take a screenshot, Amar, for now.
Okay, I just found the article.
Oh, you did?
So
you
Okay,
I'm
found it.
reading
great.
it right
Okay.
now.
Your searching is
Thanks.
better than mine. Amazing. Thanks so much, Amar.
Just Googled it. Thanks.
But I'll put my email in the chat for now. Like if anybody has more questions around VR in general, like happy to chat more about this. I also maybe could just put a plug in for our virtual reality opioid overdose. So we were talking about how that's free access for anybody with desktops. So if you go on a CAMH website, I just put the link in the chat. But yeah, like you could access that, the desktop one. So that's both the community and the clinical one as well. So back to Lindsay's point around sharing, yeah, we've decided our mandate is to be able to provide this free for everyone. So
Yeah, so any tertiary institution in Ontario that's interested in either of them, we would be more than happy to share. We also have developed one of our opioid overdose scenarios for the community, patients, family members, caregivers. So that's freely available on our CAMH Insight as well, the desktop version. And in terms of future areas of study, we're looking at the debriefing, after each of these, the desktop and the VR, we're looking at different methods of debriefing, synchronous, asynchronous, perceptor-led, AI. So there's a lot more to come from us, hopefully. And we really appreciate your time and your interest. Thank you so much for coming today. If we don't have any more questions, we'll give you the gift of time.
thanks all.